Good morning, everybody, and welcome back to the year-end review session, the last of our sessions from the previous agenda, and we will review what was left over from last time and look at what important publications or data evidence was published in the last year, in the second half of 2022. We reviewed quite a few randomized controlled trials. We reviewed a few meta-analysis last time. This time it is more meta-analysis with very few randomized controlled trials which we have left. So we'll start with the one issue which has been a point of a lot of discussion amongst critical care circles, ICU nephrology, and a lot of other issues. So that is about the timing of renal replacement therapy initiation for acute kidney injury. And what is the advantage? Is there any advantage of early initiation of renal replacement therapy in acute kidney injury? Is it beneficial to initiate renal replacement therapy for acute kidney injury for indications other than the conventional indications like oliguria, azotemia, hyperkalemia, and acidosis? This is a meta-analysis on this issue of all the randomized controlled trials. And at the end of all the analysis, what we can understand is that early renal replacement therapy initiation may have little to no difference on the risk of death at the day 30. So no advantage in 30-day mortality with the use of renal replacement therapy. And it does not make any difference to the risk of death, recovery of kidney function at 90 days. So in the recent past, there are 4 or 5 big randomized controlled trials which have been published, two of them in favor, 2 of them against. The ones in favor argue that while there is no short-term benefit, recovery of kidney function seemed to have been positive in faster in 2 studies at 90 days, but that has not been confirmed by this meta-analysis. Early renal replacement therapy also may not make any difference to those patients who are free from renal replacement therapy at the end of 30 days. And on the other side, now the meta-analysis seems to point out that early initiation of renal replacement therapy increases the risk of hypophosphatemia, cardiac arrhythmias, hypotension, and infection related to vascular cannulation in a compromised patient who is in shock and probably hypothermic. That's about the early initiation of renal replacement therapy. One path-breaking concept that has emerged in the last half of 2022 is the use of double sequential external defibrillation for refractory ventricular fibrillation called DOSE. Now, this is an important low-cost intervention which we should all consider. The first one was the study protocol for whether this is feasible or not. What essentially double sequential external defibrillation means is that it involves the use of 2 defibrillators, one set of pads which are placed in the conventional position in the standard anterior lateral position, and a second set in the anterior and posterior position, so across the sternum and on the paraspinal area. And in patients with refractory VF, that means VF that is refractory to 3 consecutive cardiogenic, 3 consecutive shocks of either 360 by monophasic or 120 biphasic shock. After 3 shocks, if the VF is persistent, it's called a refractory VF. For such shocks, this was tried as a salvage therapy. So this randomized controlled trial compared defibrillation strategy for refractory ventricular fibrillation, and they compared the vector change, which is changing the paddles versus putting standard paddles in 2 different locations using 2 defibrillators consecutively. And they found that among patients with refractory ventricular fibrillation, the survival to hospital discharge occurred more frequently among those patients who received the dual sequential external defibrillation or the vector change defibrillation than among those who received standard defibrillation. And subsequently, there was a comparison with the double sequential defibrillation versus the vector change. And both in the double sequential defibrillation was probably better than the vector change defibrillation. So this is a practice changing publication. The reason why we have discussed this is it's a simple intervention. Only thing you need is the second defibrillator, and probably the patient has to pay the additional cost for the paddles. But if you look at refractory VF and what options do you have, including prolonged hypoxic injury, there may be ventricular assist devices and mechanical support. I think this is a more feasible and more easily applicable intervention than the more expensive intervention. So this is the importance of this DOSE study for management of refractory ventricular fibrillation. An updated systematic review on the use of extracorporeal cardiopulmonary resuscitation for cardiac arrest was published in the Journal of Resuscitation. There is a lot of hope and a lot of enthusiasm about using eCPR for patients with refractory cardiac arrest. And they looked at three major studies, two from the United States between 2017 to 20, and a longer study from the Czech Republic from 2013 to 70, which both looked at pre-hospital and emergency room randomization of these patients who had an initial shockable rhythm and no restoration of spontaneous circulation after 3 shocks or stayed in the ED for less than 30 minutes. And the eCPR was initiated in the hospital, and nearly more than half of these patients got the ECMO in the treatment group with femoral cannulation done by either the cardiologist or the emergency physicians. And the mean time to establish ECMO in all these studies was around an hour's time. So with that data, they found the biggest one is the one from the Czech Republic published in 2022 with 264 patients. And they found that the midterm survival was not better with those who were subjected to eCPR. The midterm favorable neurological outcome was probably better in those who had eCPR, and long-term survival, however, did not change in the patients who had eCPR. So eCPR is feasible. It can be established in a short period of time. It improves short-term neurological outcomes, but more studies need to be done to establish long-term favorable outcomes for patients with refractory cardiac arrest. This is the summary of the updated systematic review. Hemoperfusion, again, has been in and out of intensive care units for a long time. We have used it for endotoxemia, which did not stand the test of scrutinies of randomized controlled trials. It is used in some poisonings. Charcoal hemoperfusion is used for some poisonings. Cytokine adsorption again became a hype again a big craze during the COVID pandemic. But a common poisoning like organophosphate and carbamate, we did not actually look at till recently. So this study from South Africa, this is a randomized controlled trial looking at hemoperfusion using an adsorbent cartridge for clinically suspected severe organophosphate and carbamate poisoning. Now, this severity was based on the clinical severity of the poisoning, not based on the enzymatic severity. And this study, which looked at about 300 plus patients with significant organophosphate and carbamate poisoning, found that the hemadsorption therapy or hemoperfusion therapy resulted in significant cost savings driven by a reduced length of stay among the patients with excess length of stay more than 7 days. It was also associated with a significant reduction in the combination of 28-day mortality and severe complications including cardiac arrest, organ dysfunction, reintubation, and tracheostomy. So they did not specifically talk about the prevalence or incidence of intermediary syndrome, but the data seems to suggest that a good number of their patients before the use of this study ended up with reintubations and tracheostomy. So these were patients who had some neuromuscular weakness as a result of the poisoning. So in that context, if you have a patient who has severe poisoning with neuromuscular failure requiring invasive ventilation, you may consider using hemoperfusion, which using a HA230 cartridge for patients with severe suspected organophosphate and carbamate poisoning. Maybe a country like ours, which has a large database of such for patients, can do a randomized controlled trial, but the costs incurred in purchasing the cartridge would probably be the deterrent for this. Now, aspiration of gastric contents is something we are all aware of, and we all believe that continuous closed suction, the subglottic suction system, head end elevation can actually reduce the incidence of aspiration pneumonia in patients. But intra-abdominal pressure has never been looked at as one of the contributory factors for patients who have developed aspiration. And we pick up aspiration based on hypoxemia, based on chest infiltrates, and change the ventilator compliance. But a biochemical evidence of aspiration was first time evaluated in this study, which looked at the relationship between intra-abdominal pressure and microaspiration of gastric contents in critically ill mechanically ventilated patients. What they have done is they have tried to look at the levels of pepsin in the bronchoalveolar lavage or the tracheal secretions among patients who had variable levels of intra-abdominal pressures. And they found that pepsin and total protein levels in the bronchoalveolar lavage were significantly elevated in patients with intra-abdominal hypertension of more than not essentially intra-abdominal hypertension, but an intra-abdominal pressure of more than 8 millimeters of mercury compared to the controls. And the peak of pepsin values correlated significantly with the peak intra-abdominal pressure of these patients. Therefore, this study concluded that intra-abdominal pressure was an independent risk factor for increased pepsin values in bronchial washings or bronchial fluid. And pepsin values were higher in patients with ventilator-associated pneumonia, while intra-abdominal pressure was independently associated with ventilator-associated pneumonia. Therefore, in the end, they concluded that there was an indication towards increased VAP in patients with increased pepsin, and intra-abdominal pressure is probably the cause of a significant amount of these patients who develop ventilator-associated pneumonia in the intensive care unit. So, every patient who is in the ICU for more than 72 hours, having received fluid resuscitation and on mechanical ventilation, should probably have his intra-abdominal or her intra-abdominal pressure measured at least twice a day to ensure that this does not become a risk factor for a preventable complication in the intensive care unit. So, in conclusion, pepsin in the bronchial secretions may be elevated when the IAP is increased, indicating the chances of microaspiration and potentially a ventilator-associated pneumonia. So, while we may not always be able to measure the pepsin levels in the BAL for these patients, we can use the other conclusion that measure the intra-abdominal pressure, and if the pressure is high, consider your patient to be at a high risk of ventilator-associated pneumonia. Oxygen targets have always been a point of debate, and a lot of studies, the ICU rocks, the oxygen ICU, and so many studies were published in 2021, which we reviewed previously. Two randomized controlled trials, essentially from the same group, looked at oxygen saturation targets and blood pressure targets for critically ill adults receiving mechanical ventilation. They looked at a saturation target of 65 to of a PaO2 of 65 to 75 and a saturation of above 90 versus a PaO2 of above 75 with a saturation of above 95 for patients with receiving for critically adults receiving mechanical ventilation. So among critically ill adults receiving invasive mechanical ventilation, the number of ventilator-free days did not differ among groups in which a lower, intermediate, or a higher SpO2 target was used. So again, like in our previous studies, those who believe in higher oxygen targets would say there is no harm, whereas those who believe in lower oxygen targets would say that it is safe. What we can also say is that keeping a moderate level or lower levels of target, which will help us to probably reduce the amount of PEEP, reduce your driving pressures, which will probably help us to keep mechanical ventilation safer. Similarly, oxygen targets were studied among, and blood pressure targets were studied among comatose patients of surviving from cardiac arrest. It was honestly believed that oxygen target should be higher, PaO2 should be higher in those who have survived from a cardiac arrest. They found this study looked at again the same levels of saturation of keeping the PaO2 above 65, above 70 or above 80, and they found that targeting of a restrictive or liberal oxygenation strategy in comatose patients after resuscitation for cardiac arrest resulted in a similar incidence of death or severe disability or coma. So having a higher target of oxygen delivery for these patients does not guarantee a favorable neurological outcome. So we need not overdo the mechanical ventilation for survivors of cardiac arrest from the oxygen point of view. The same group also studied the blood pressure targets in comatose survivors of cardiac arrest, and they looked at a mean arterial pressure of 63 versus a mean arterial pressure of 77. And they found that targeting a mean arterial blood pressure of 77 millimeters of mercury or 63 millimeters of mercury in patients who had been resuscitated from cardiac arrest did not result in significantly different percentage of patients who died after cardiac arrest or were having severe disability or coma. So again, less is more seems to be coming back into this field of management of patients with cardiac arrest who are neurologically obtunded. Regional citrate anticoagulation has come back into force in critical care nephrology circles for CRRT, especially among coagulopathic septic patients. And it has been projected that this is a safe way of administering anticoagulation to patients who probably would not have tolerated higher levels of anticoagulation. But a comparative study comparing regional citrate anticoagulation versus systemic heparin for CRRT in the intensive care unit was evaluated in non-coagulopathic patients, and they found that if you look at they looked at a system where this is from the ICNAR group, where they looked at costs and safety. And if you look at this gray bar, this is the timeline before, when they made the transition from heparin anticoagulation to regional citrate anticoagulation. And they found no difference in the 90-day mortality in the era before regional citrate and the era after the use of regional citrate. Similarly, there was not much difference between the ICU length of stay when heparin was used as anticoagulation versus regional citrate for was used for anticoagulation. The renal support, the number of days of renal support probably was a little longer after the use of citrate because the cartridge life obviously got prolonged with the use of regional citrate anticoagulation. The need for hemodynamic support and the bleeding episodes in the ICU did not differ much in the patients who were given heparin. Although there was some advantage in the bleeding patients, there was some advantage by using a regional citrate anticoagulation compared to using conventional heparin for these patients. But the risk of thromboembolic episodes probably increased a little bit more with regional citrate anticoagulation than when compared with heparin. So this study concluded that transition to regional citrate anticoagulation was associated with significant increase in healthcare resource use without a corresponding clinical benefit and is highly unlikely to be cost effective over a 1-year time horizon after the initiation of regional citrate anticoagulation. So the enthusiasm about regional citrate anticoagulation probably is not as justified as we think it is, and probably should be reserved for a highly selected group of bleeding coagulopathic patients in the intensive care unit. Early versus late tracheostomy has again been a point which has never been conclusively been proven or disproven, the TrackMan being the largest and the most pragmatic of these trials. And all these routine statistical analysis of systematic reviews have shown no benefit. So a Bayesian analysis was done for systematic review of early versus late tracheostomy in the ICU patients. But if you look at this column of timing of tracheostomy, there is a lot of heterogeneity in what is actually early tracheostomy. Some of them believe it is 2 to 3 days. Some of them have done it at 5 to 6 days, less than 2 days, right? And some of them have done between less than 7 days. So if you look at the ones which are more recent, they have done between 5 and 7 days. The Malaysian, the American, the German, and the Swedish studies, they've all done between 5 and 7 days and called a tracheostomy late when it was done more than 80 days. So if you look at this data, you can see that the short-term mortality probably is a little better with the use of early tracheostomy. The risk of VAP is probably a little better with early tracheostomy, and the duration of mechanical ventilation is probably lesser with the use of early tracheostomy. So this meta-analysis, this Bayesian analysis seems to suggest that there is evidence that the risk of all adverse clinical outcomes is reduced for early versus late tracheostomy, with the possibility of more than 90% for any benefit and 75% for a small benefit, apart from the duration of mechanical ventilation, where the difference was reasonably big. The most interesting study I can actually find is that the endotypes of traumatic brain injury in an intensive cohort. So we always believe that Glasgow Coma Score is one of the strongest predictors of outcome, and we tend to categorize these patients as mild, moderate, and severe traumatic brain injury based on the Glasgow Coma Scale. But this single point stratification of patients with traumatic brain injury fails to capture the enormous heterogeneity in the pathophysiology and treatment response. Most of us who have treated these patients would have found that the sick patients whose GCS was less than 8 actually tended to recover, while those who are doing well with a score of more than 12 deteriorated over a period of time. For this purpose, a metabolic stratification of patients with metabolic stratification of patients with traumatic brain injury was made, with those with a high GCS, that is 13 to 15, intermediate between 9 to 12, and a low GCS of 3 to 8, again divided into two groups of normal metabolism and deranged metabolism. Normal metabolism would mean a normal metabolic profile, older patients and anticoagulation. Whereas the deranged metabolism would mean high glucose, high lactate, acidosis, hypothermia, elderly patients, midline shift, but did not require decompressive craniectomy or requiring mechanical ventilation. So some of these, especially if the GCS is low and they have shock or acidosis or hypothermia, extracranial injuries, and secondary insults, the outcome is unfavorable. So even if your GCS is 9 to 12, but you have metabolic derangements like high glucose, high lactate, acidosis, hypothermia, and midline shift, you tend to do worse than patients who have a low GCS and a normal metabolism. So the crux of this story is, if there is a patient with a moderate or a mild TBI and has metabolic derangements like high glucose, high lactate, low bicarb, and low temperature, we should pay more attention to these patients, as much attention to these patients as you pay to the patients with severe traumatic brain injury. If you look at the mortality, the cluster C patients who had moderate TBI and high glucose had highest mortality when compared to the patients who had severe TBI with no metabolic derangements, right? At the same time, if a patient has a severe TBI with a very low GCS and with extracranial injuries or with secondary insults or needing decompressive craniectomy, the mortality was higher. So it is not just the mild, moderate, severe TBI based on GCS that makes a difference. Common metabolic tests which are routinely applied in the intensive care unit should become an integral part of the severity scoring and therefore prognostication among patients with traumatic brain injury. Similar algorithms for ICU mortality and length of stay using machine learning has been proposed. Machine learning and artificial intelligence have now become integral parts of intensive care approach. All the discussion we had in the previous session and today seem to focus on a lot of phenotypes of ARDS, phenotypes of sepsis, and now we have seen phenotypes of traumatic brain injury. All these phenotypes have been made possible. Identification of these phenotypes has been made possible because of the application of the AI algorithms. So these AI algorithms seems to suggest that in patients who are septic or in patients who are in the intensive care unit, three parameters, your lactate, your LDH, and your platelet count would predict a higher mortality irrespective of the basic diagnosis and would predict a higher length of stay in the intensive care unit. So for surgical patients, elective surgery, a low heart rate and a normal LDH are very good predictors of outcome, whereas for adverse outcome, elevated LDH, elevated blood urea nitrogen and tachycardia are important predictors of long ICU stay for surgical patients. So use of artificial intelligence seems to be the next big thing, and maybe we will see more such studies when we review the year in review next year. Thank you very much. If there are any requests for these articles, please do drop in a message on the WhatsApp chat. Some of these are only available as abstract to us at this point of time. As soon as they are available to us in full text, we will share with you. Thank you very much. Next week, we will restart the routine schedule with a talk on, we will start with the group, a cluster of talks on tropical diseases. And the first one will be dengue, that will be dealt with by Dr. Ahad and guided by Dr. Manindra. Thank you very much. Have a good day. And we will catch up.
Yes.
Ghanshyam, you want to add something? Sorry.
No, nothing to add. But among all the studies or the literature that you have reviewed over the last 1 year, do you think anything that can be looked at by students to pick up as their project for research? Since we have so many DNBs, some important topics which can be actually looked upon by some of these to look at the future research. Can be
easily done, as I said.
Not easily done, but something interesting.
Yeah, so the one thing which can be easily done is the intra-abdominal pressure measurements for all patients in the intensive care unit and the adverse incidents related to it. You can look at aspiration pneumonia, you can look at length of ICU stay, length of mechanical ventilation is something we can do that can be easily done. Oxygen targets, you can actually look at oxygen targets for in-hospital cardiac arrest versus out-of-hospital cardiac arrest. They can do a comparative study and see, because we get a good number of these patients. So keep mild, moderate, and severe group. Keep a mild, moderate, conservative and liberal targets. Keep the PaO2 of 65 and 75 or 65 and 85. That's something that can be easily done for these patients. And we have described so many phenotypes of traumatic brain injury and sepsis. They can validate these phenotypes in tropical diseases in an Indian context.
Thank you, seniors.
Thank you very much. We'll see you all again next week. Bye.